Hi everyone, my name is Casey Wiesen, and today we're going to talk about the endocrine function, which is chapter 10 of your textbook. Just like previously, I will give an overview of the anatomy and pathophysiology of the endocrine system and various disorders that impact this system. The information in this lecture is not comprehensive in regards to your exam, so I still recommend you read the chapter 10 in your textbook. The endocrine system consists of glands located throughout the body, and these glands are responsible for producing and secreting a wide range of hormones and chemical transmitters. The hormones serve as chemical messengers traveling to the various sites to regulate several processes, including growth and development, metabolism, sexual function, reproduction, and mood stability. Small amounts of these substances are all that is required to make a significant impact at the cellular and organism levels, and subsequently, small fluctuations in hormone levels can disrupt the body's delicate balance. The endocrine system is a complex messaging and control system that interacts with several body functions. Endocrine glands located throughout the body produce and secrete hormones that are used to orchestrate multifaceted communication and control operations. The term endocrine refers to the act of secreting substances directly into the bloodstream rather than into a duct. Hormones are classified or described by their action, source, or chemical structure. The four categories based on chemical structure include steroids, proteins or polypeptides, amines, and fatty acid derivatives. Hormone release is influenced by the nervous system, other chemical substances, and one endocrine gland influencing another. Release of hormones from their respective gland is primarily controlled by a negative feedback system, but may occasionally be controlled by a positive feedback system. In a negative feedback loop, the product, and in this case that is a hormone, of a biochemical process inhibits its own production. Or in other words, the hormone is released only when its levels decline and production stops when the levels rise. In the endocrine system, positive feedback loops are rare and occur when a hormone is released when levels are high and production stops when its levels are low. Tropic hormones, an example of this is the thyroid stimulating hormone, regulate endocrine glands to produce other hormones. Non-tropic hormones, for example cortisol, directly stimulate cellular metabolism and other activities. Once released from the gland, hormones signal in different manners. In endocrine signaling, hormones travel through the circulatory system to a distant target cell located in other glands and tissues. See figure 10-2 and 10-3. Autocrine signaling involves identical cells synthesizing, secreting, and responding to their own hormone through receptors. The signaling cell and the target cell can be the same or similar. In paracrine hormone signaling, the hormone acts on receptors of nearby cells. Multiple hormone signals continuously interact with target cells, but these cells respond only to their specific hormone. This selective response is due to protein receptors located in the cell membrane or the cytoplasm. The number of receptors on the target cells and the sensitivity of the receptors to the hormones can change depending on hormone concentration. Upregulation is the process which low hormone levels cause an increase in the number of cell receptors, and downregulation is when high levels of hormone decrease the number of receptors or decrease the cell's affinity to the hormone. For hormones to cause a reaction, they must be in a free form. Water-soluble hormones such as insulin are already circulating in free forms, whereas lipid-soluble hormones such as glucocorticoids are bound to a carrier protein. And a lipid-soluble hormone reaches its target cell, dissociates from its carrier protein, and then enters the cell. And a common carrier protein is albumin. Once the hormone has acted on the target cells, the liver metabolizes the hormone and the kidneys excrete it to prevent a cumulative effect. The pituitary gland is approximately the size of a pea and located at the base of the brain. The gland is divided into the anterior and posterior gland and is often referred to as the master gland. Even though this gland is small, it secretes several hormones that influence many different body functions. See Figure 10-4 and Table 10-1 for more information. The hypothalamus regulates the pituitary gland and is connected to the pituitary gland through the pituitary stalk and connects the nervous system and endocrine system. The hypothalamus contains receptors that monitor hormones, nutrient, and ion levels, and when activated, these receptors stimulate neurosecretory neurons in the hypothalamus to synthesize and secrete various types of releasing and inhibiting hormones. The hormones that are part of the hypothalamus regulate the hormones produced by the anterior pituitary gland in a relationship known as the hypothalamic pituitary axis. The hypothalamus neurosecretory neurons also synthesize the posterior pituitary hormones, which include ADH and oxytocin. The posterior pituitary hormones, in contrast to the anterior pituitary hormones, travel through a nerve tract and not a circulation portal. See Figure 10-2. The posterior pituitary hormone have a direct effect on peripheral tissue. The pancreas is an organ with both exocrine digestive function and endocrine functions. The pancreas lies underneath the liver and between the two kidneys in the retroperitoneum. Its endocrine functions are carried out by the islets of Langerhans, and the pancreas contains approximately 1 million of these. Each islet of Langerhans contains 5 types of cells: alpha cells, beta cells, delta cells, pancreatic polypeptide, and epsilon cells. The regulation of glucose is reflected in the balance between energy intake and energy use, with insulin as a key hormonal regulator. Excuse me. Glucagon is released when serum glucose levels fall, insulin levels drop, or glucose needs increase. Glucagon stimulates the breakdown of glycogen to glucose in the liver, which raises serum glucose levels. Gluconeogenesis occurs when glucagon stimulates the liver and, to a small extent, the kidneys. Glucagon also decreases the uptake of glucose in skeletal muscle and fat and promotes the release of amino acids and fatty acids. On the other hand, high blood glucose inhibits glucagon release. Insulin is released when serum glucose levels increase, and the insulin stimulates cellular uptake of glucose, which in turn decreases serum glucose levels. Insulin also promotes the storage of carbohydrates, fats, and proteins. Amylin is released from these beta cells along with insulin, and amylin has a synergistic relationship with insulin in controlling glucose. Several hormones that are secreted in the GI tract that affect pancreatic hormones and in turn glucose regulation. These hormones include incretin from the small intestine and ghrelin from the stomach. The key types of incretin hormones are glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide. After a meal, the incretins cause insulin release and inhibit glucagon release. Incretins also delay gastric emptying and decrease appetite. Dipeptidylpeptidase 4 is the enzyme that causes breakdown of incretins, and some medication classes used to treat type 2 diabetes target these. The thyroid gland is located at the base of the neck below the larynx and consists of 2 lobes. The thyroid is highly vascular and contains several follicles, which are functional units. These follicles produce 3 hormones: T4, T3, and thyrocalcitonin or calcitonin. T3 and T4 account for 95% of circulating thyroid hormones, and they help regulate cellular metabolism as well as growth and development. The hypothalamus releases thyrotropin-releasing hormone, which stimulates the anterior pituitary gland to produce thyroid-stimulating hormone, or TSH, using a negative feedback loop. TSH then drives the thyroid to produce more T3 and T4. Most of the T4 is produced by the thyroid gland, or approximately 90%, while only a small amount, or approximately 10% of T3 is produced by the thyroid gland. The remainder of T3 is produced when T4 is converted to T3 in body tissues. The thyroid requires iodine to synthesize these hormones. Calcitonin, along with the parathyroid hormone, regulates serum calcium levels, especially when serum calcium levels are high. Calcitonin reduces calcium levels by inhibiting osteoclast activity and stimulating osteoblast activity. Calcitonin also regulates calcium and phosphate by decreasing renal tubular reabsorption and possibly decreasing GI absorption. Parathyroid glands typically consist of 4 glands located on the posterior surface of the thyroid, and each gland secretes the peptide parathyroid hormone, or PTH. PTH works in the opposite way of calcitonin to regulate serum calcium levels, and PTH is more important than calcitonin in calcium regulation. The parathyroid glands have highly sensitive calcium sensing receptors on their cells, and PTH is secreted when serum calcium levels drop. This hormone increases serum calcium levels by increasing osteoclast activity and inhibits osteoblastic activity, which results in decreased bone deposition. PTH also raises calcium levels by increasing the absorption of calcium in the GI tract and reabsorption from the kidneys. PTH decreases serum phosphate levels, and the net effect is an increased calcium level and decreased phosphate level. Calcium levels are regulated through the action of PTH on the kidney. PTH stimulates vitamin D3, and together they increase calcium and phosphate absorption in the intestines and reabsorption from the kidneys. Adrenal glands are located on each kidney, and the hypothalamus influences both portions of the adrenal glands, as each adrenal gland has an outer portion, or the cortex, and an inner portion, or the medulla. The adrenal cortex is regulated by negative feedback involving the hypothalamus and adrenocorticotropic hormones, whereas the medulla is regulated by nerve impulses from the hypothalamus. The medulla produces epinephrine and norepinephrine during times of stress, and these help mediate the fight or flight response of the sympathetic nervous system. See Figure 10-8. The adrenal catecholamines are also regulated by glucocorticoids and ACTH. The cortex has 3 separate regions that produce different steroids. The outermost region secretes mineralocorticoids, with the principal mineralocorticoid being aldosterone, and aldosterone is primarily regulated by the renin-angiotensin-aldosterone system. The middle region of the adrenal cortex secretes glucocorticoids, and the primary glucocorticoid is cortisol, which increases serum glucose levels. Glucocorticoids have effects on the metabolic, neurologic, immune, and musculoskeletal systems, and glucocorticoids are released during stress. The innermost region of the cortex secretes gonadotropins, or sex hormones, and these hormones include DHEA, DHEAS, and androstenedione. These hormones are secreted in minimal amounts in both sexes by the adrenal cortex, but hormones from the testes and ovaries. Now I'm going to cover a couple specific conditions that affect the endocrine system. Like my other lectures, this will not be a comprehensive list and will include those that I most commonly see in my practice. Please refer to your textbook to learn about all conditions that affect the endocrine system. So up first is diabetes mellitus, and this refers to a group of conditions characterized by hyperglycemia that results from defects in insulin production, insulin action, or both. Glucose is a vital energy source for the body, but insulin is required for glucose to travel into the cell where it can be used. Insulin acts like a key that unlocks the cell membrane that allows the glucose to enter. Impaired insulin production or action results in abnormal carbohydrate, protein, and fat metabolism because of the glucose transportation issue. There are 3 main types of diabetes: type 1, type 2, and gestational. There is also a less common form called monogenic diabetes, and diabetes can also result from diseases of the exocrine pancreas, such as occurs with cystic fibrosis, Cushing's disease, or pancreatitis. So diabetes is very common in the U.S. Approximately 30.7 million Americans have diabetes, and an additional 84.1 million Americans have prediabetes. The chance of developing diabetes is equal across genders and more common in older adults. And while diabetes is the seventh most common listed cause of death in the U.S., it likely plays a role in many more deaths because the disease contributes to several complications such as heart disease, stroke, and kidney disease. While I did mention there are multiple different types of diabetes, today I will cover type 1 and type 2 as those are the ones I most commonly see in my practice. Type 1 diabetes accounts for approximately 5% of all newly diagnosed cases of diabetes, and to survive, people with type 1 must obtain insulin by injection or a pump. Type 1 is typically diagnosed in children and young adults, but its onset can occur at any age. Type 1 diabetes is categorized into type 1A and type 1B. Type 1A is more common and develops when the body's immune system destroys pancreatic beta cells, leading to absolute insulin deficiency. Initially, there may be a short period called the honeymoon phase where residual beta cells are producing insulin, but as more and more insulin is needed, like during an infection or puberty, the insulin reserve disappears and insulin becomes nearly absent to completely absent. The exact cause of type 1A is unknown, but most likely a viral or environmental trigger is genetically susceptible. But most likely a viral or environmental trigger in genetically susceptible people causes an autoimmune reaction. With type 1A diabetes, beta cells are destroyed by the immune system, and although there is sparing of other pancreatic cells, hormonal patterns from these cells are altered. Type 1A diabetes is associated with multiple genes, with one of the major susceptibility genes found on the human leukocyte antigen region of chromosome 6. Various autoantigens initiate or are involved in the progression of beta cell destruction, and these autoantigens can be measured in the serum to confirm the diagnosis of autoimmune type 1A diabetes. A variant of type 1 diabetes that is also the result of autoantibody beta cell destruction is known as latent autoimmune diabetes of adults, or LADA. Those with LADA are often diagnosed in adulthood, and due to their age, it is often thought that they have type 2 diabetes. These individuals tend to have a more gradual beta cell destruction and a longer period of symptoms of hyperglycemia compared to children. Insulin therapy may not be needed initially, and patients with LADA may have autoantibodies such as GAD and islet cell antibodies. Type 1B diabetes is less common and leads to beta cell destruction and almost complete insulin deficiency. In contrast to type 1A, there is no evidence of autoimmunity and the cause of the destruction is unknown. Therefore, type 1B is considered idiopathic and there is usually a hereditary component. Type 2 diabetes accounts for approximately 90 to 95% of all newly diagnosed diabetes cases in adults. This form of diabetes usually begins as insulin resistance, a disorder in which the body's cells do not use insulin properly. As the need for insulin rises, the pancreas gradually loses its ability to produce insulin. Type 2 is often associated with advancing age, obesity, family history of diabetes, history of gestational diabetes, impaired glucose metabolism, and physical inactivity. Type 2 diabetes in children and adolescents is rare, but is being more frequently diagnosed. The common phenotype in diabetes is hyperglycemia, but various ethnic groups may have different pathogenesis. Development of type 2 diabetes is considered multifactorial and polygenic. Multiple genes and environmental influences such as obesity, poor nutrition, and inactivity contribute to the development of type 2 diabetes, and type 2 is hereditary. The pathogenesis of type 2 diabetes starts with insulin resistance, which refers to the insulin's inability to act upon target tissues. The lack of glucose use causes the liver to produce more glucose in response. Both processes, lack of use and increased production of glucose lead to hyperglycemia. Hyperinsulinemia occurs as a compensatory response. Ultimately, the beta cells struggle with the maintaining the hyperinsulin state, so insulin secretion decreases, hepatic glucose production increases, and beta cell failure occurs. Glucagon additionally increases hepatic glucose production due to inadequate insulin suppression, further compounding the hyperglycemia. Impaired insulin secretion by beta cells is also a result of genetic influences, and individuals with type 2 diabetes have varying degrees of beta cell dysfunction. The genesis of insulin resistance is unclear, but a known risk factor for type 2 diabetes is the development of obesity. Obesity is present in approximately 80% of those with type 2 diabetes, and when weight is lost, insulin responsiveness improves. Obesity, especially when the fat is in a central or visceral location, may be related to the development of insulin resistance through various mechanisms. Free fatty acids are extremely high in the plasma of obese individuals and may contribute to impaired glucose uptake and decreased insulin secretion. Adipocytes release adipokines such as leptin, adiponectin, and resistin, and other chemicals such as tumor necrosis factor alpha, which stimulate inflammatory activity. These various factors released from adipose tissue may be increased or decreased and contribute to the development of type 2 diabetes. In type 2 diabetes, several inflammatory markers are increased, and some medications used to treat type 2 diabetes have an anti-inflammatory property. The mechanism by which insulin secretion decreases is unclear. Amylin, which is stored in beta cells and is co-secreted with insulin, may contribute to islet cell destruction through the accumulation of amyloid deposits. With beta cell decline, amylin becomes deficient in type 2 diabetes. Chronic hyperglycemia and inflammatory markers in the islet environment may contribute to impaired islet functioning and destruction. Altered functioning of glucagon-like peptide and incretin hormone may reduce insulin secretion. Clinical manifestations of diabetes can range from asymptomatic to life-threatening diabetic ketoacidosis, and the presentation between type 1 and type 2 diabetes can vary. Most patients with type 2 diabetes are asymptomatic, and the diagnosis is often made through routine lab work. In contrast, type 1 diabetes may present with DKA. The manifestations of diabetes, which are a result of hyperglycemia, may include glucosuria, polyuria, polydipsia, polyphagia, weight loss, blurred vision, fatigue, nausea, vomiting, and abdominal pain. Diabetes can result in various acute and chronic complications too. The acute complications are related to excessive alterations in blood glucose, which may be too high or too low. Hypoglycemia is low plasma blood glucose levels with or without symptoms and may result in harm. This is often caused by insufficient dietary intake, increased physical activity, and diabetic medication therapy, and is more common with those who use insulin. Hypoglycemia is typically defined as glucose levels less than 70. However, the glycemic threshold that can cause symptoms and activate counter-regulatory responses can vary from person to person. If symptoms are present, this is caused by an autonomic response to the low glucose and may include palpitations, tremor, anxiety, sweating, hunger, and paresthesias. Symptoms mediated by the actual low glucose include dizziness, weakness, drowsiness, confusion, and delirium, as well as seizure and coma with extremely low levels. Hyperglycemia may be the result of excessive dietary carbohydrate intake, as well as insufficient or inappropriate diabetic medication management. Two serious complications of diabetes that reflect extreme hyperglycemia include DKA and hyperosmolar hyperglycemic non-ketotic state, or HHNK. The major causes of these two complications are insulin deficiency and/or resistance, as well as glucagon excess. Often, patients present with varying degrees of clinical manifestations precipitated by hyperglycemia. See Figure 10-12. DKA is usually associated with type 1, and HHNK is more commonly associated in those with type 2. DKA is more common than HHNK, but mortality is higher with HHNK. For more information regarding DKA and HHNK and the various metabolic abnormalities and pathogenesis, refer to pages 521 through 524. Diagnosis is usually made with labs evaluating the glucose status, and labs are also used to assess the effectiveness of diabetes management. The various glucose tests include a fasting blood glucose test, oral glucose tolerance test, which is most accurate for diagnosis in pregnancy, random blood glucose test, and a hemoglobin A1C. And a hemoglobin A1C is an average of the glucose control for the previous 3 months. For type 1 diabetes, various autoantibodies can be evaluated as well. Treatment for diabetes varies depending on the type, but dietary changes and exercise are the first line of treatment. Management also includes close self-monitoring, weight loss if applicable, oral or non-insulin injectable hyperglycemia medications, insulin and complication management. Also, bariatric and metabolic surgeries have shown promise as potential cures for diabetes. Next is obesity. Obesity is a chronic metabolic and endocrine disorder which is characterized by abnormal or excessive fat accumulation. It is defined as a BMI of 30 or greater, and overweight is defined as a BMI of 25 or greater. The incidence of obesity worldwide has tripled since 1975, and it is on the rise in the United States with 42% of adults affected and 19.3% of children and adolescents. Obesity develops because of an imbalance between caloric intake and energy expenditure. The reasons for the imbalance are multifactorial and complex, and obesity development often includes genetic, epigenetic, physiologic, environmental, behavioral, and sociocultural factors. There is also a hereditary component to obesity. And while it is well known that obesity is hereditary, it has been difficult to identify the genes. Energy expenditure is determined by resting or basal metabolic processes, which include energy needed for processes such as cellular membrane exchanges and heart, lung, and GI function. Most energy expenditure is used for these metabolic processes, even though this is the energy needed during a physical inactive state. The basal metabolic rate is also defined as the minimum number of calories needed to live. Low energy expenditure, such as that which occurs in a sedentary lifestyle, will cause weight gain. Energy expenditure is also influenced by types of food ingested, with some foods expending more energy than others. Different types of fat in the body influence energy expenditure. Fat or adipose tissue types include white adipose fat, brown adipose fat, and beige adipose fat. White adipose fat is the most abundant in the body and responsible for the many functions of fat, which includes storage of excess calories as an energy reserve. Excess of white fat causes dysregulation of multiple adipokines. White adipose fat is found deep within the body, or visceral fat, and in the periphery as subcutaneous fat. Increases in visceral fat, primarily around the intra-abdominal cavity, are associated with increased complications such as cardiovascular disease and diabetes. Hormonal changes may be a reason why fat mass increases during middle age. White fat can become beige fat, which is an energy expending type of fat. Brown fat is considered a good fat and primarily regulates energy usage, particularly maintenance of warmth in newborns and usage peaks around puberty. The amount of brown fat decreases with age but continues to remain metabolically active and is stimulated with exposure to cold weather. Brown fat is located mainly in the upper torso, in the neck and clavicular area, and the more active the brown fat, the lower the BMI and body fat percentage. Leaner individuals have more brown fat, and investigations are currently being performed to determine how to increase and stimulate brown fat and how to stimulate the conversion of white fat to beige fat so that weight loss can be achieved. Body weight and fat stores are regulated by the central and peripheral nervous system, and several GI hormones are involved in regulation of food intake. See Figure 10-13. These hormones are either associated with appetite stimulation and increases in food intake, or associated with appetite suppression and inhibit food intake. Examples of hormones that increase food intake include ghrelin. Hormones that inhibit food intake include leptin, glucagon-like peptide 1, cholecystokinin, pancreatic polypeptide, and peptide YY3-36, and amylin. Obesity is associated with many complications, especially cardiometabolic disorders such as hyperlipidemia and hypertension, type 2 diabetes, polycystic ovarian syndrome, and non-alcoholic fatty liver disease. Several of these disorders are caused by the chronic, low-grade inflammatory state created by adipocytes in white fat. Immune cells in the white fat release various inflammatory cytokines. The inflammatory state is further maintained by various adipokines such as adiponectin, leptin, and resistin. Adiponectin levels are decreased while leptin and resistin levels are increased by obesity. The excess fat of obesity is associated with various biochemical disorders such as GERD, osteoarthritis, sleep apnea, and urinary incontinence. Various cancers are also associated with obesity, such as colon, pancreatic, breast, and endometrial cancer. A statistic I found interesting in your book stated that approximately 40% of all cancers diagnosed are attributed to obesity and overweight. Reproductive effects include abnormal menses and infertility, and psychosocial problems may arise, such as depression. Clinical manifestations of obesity are related to the complications that it causes. Some individuals are obese and have no complications, and these individuals are considered metabolically healthy obese. Fat distribution may confer different degrees of risk for obesity-related complications, and those with greater visceral fat distribution are at risk for more complications compared to those whose fat distribution is in the subcutaneous or buttocks and thigh region. Diagnosis is often made using BMI, but BMI does have its limitations, which can include overestimation of body fat in athletes or those with a muscular build, and underestimation of body fat in older people and others who have lost muscle mass. Other tools can be used, which include waist circumference and growth chart percentiles, and BMI are used to diagnose obesity in children. Other body composition analysis tests can be done, such as bioelectrical to evaluate fat mass, air-water displacement, plethysmography, or dual energy X-ray absorptiometry can be used. Diagnostic tests will also be done to assess risk of developing complications or to monitor management of complications such as lipid profile, electrolyte, glucose, renal function, and liver enzyme analysis. Treatment is focused on weight and fat reduction. Lifestyle and behavioral therapies include healthy eating and physical activity. Various diets can be used, such as a low-calorie, low-fat, low-calorie, moderate-fat, low-calorie, and low-carbohydrate diets. The most important part of weight loss is not the type of diet, but the adherence to the diet. If weight loss is not achieved with lifestyle changes, then medications can be added. Bariatric surgery is another strategy that is indicated for those with the BMI greater than 40, or those with the BMI greater than 30 and have obesity comorbidities or difficulties with controlling their diabetes. There are multiple types of bariatric surgery, including Roux-en-Y bypass and sleeve gastrectomy. Next is hypothyroidism. Hypothyroidism occurs when the thyroid does not produce enough thyroid hormone. This disorder is relatively common and is more common in women than men. It can be congenital or acquired, and several conditions can result in hypothyroidism. In many cases, a previous or current inflammation of the thyroid gland leaves a large percentage of thyroid cells damaged and incapable of producing sufficient hormone amounts. Causes of this may include infection, medications such as amiodarone or lithium, trauma, or autoimmunity. The most common cause of inflammation of thyroid is chronic autoimmune thyroiditis or Hashimoto thyroiditis, which can lead to thyroid gland failure. In chronic autoimmune thyroiditis, antibodies and T cells destroy thyroid antigen cells. Under normal circumstances, the thyroid follicle cells take up thyroglobulin when stimulated by TSH. TPO is the enzyme that oxidizes iodide to iodine, which is necessary for thyroglobulin to yield T4 and T3. T4 is deiodinated in the peripheral tissues to form T3. In chronic autoimmune thyroiditis, B cells in the thyroid gland produce IgG-type antibodies to thyroglobulin and TPO. The T cells secrete cytokines that regulate an immune response and ultimately destroy the thyroid cells. Thyrotropin receptor antibodies mimic TSH and are present in chronic autoimmune thyroiditis. A variant of chronic autoimmune thyroiditis is postpartum thyroiditis, and with this condition, there is an autoimmune destruction of the gland. Risk factors for development include women with type 1 diabetes, family history, and history of postpartum thyroiditis with prior pregnancies. Postpartum thyroiditis usually occurs within 1 year postpartum and can occur after a spontaneous or induced abortion. The second major cause of hypothyroidism is iatrogenic, or when the condition results from medical treatment. The treatment for many thyroid conditions, such as hyperthyroidism, warrants partial or complete surgical removal of the thyroid gland. So, if the total remaining thyroid hormone producing cells are not able to meet the needs of the body, hypothyroidism develops. This result is often the goal of surgery for thyroid cancer. Clinical manifestations of hypothyroidism vary widely and develop slowly often over several years. Severe hypothyroidism, which is known as myxedema, Severe hypothyroidism, which is known as myxedema coma, is rare and more likely to occur in those with long-standing hypothyroidism or poorly controlled hypothyroidism in combination with a precipitating event such as infection or opioid administration. Diagnosis for hypothyroidism includes a history and physical exam, serum thyroid hormone levels, and serum TSH. Diagnosis is made based on the thyroid levels and TSH. Primary hypothyroidism results in a high serum TSH and low serum free T4, and total T3. If the TSH is high and the T3 and T4 are normal, the patient is diagnosed with subclinical hypothyroidism. Hypothyroidism is easily managed with thyroid hormone replacement, such as levothyroxine. The effectiveness of the dose is usually checked about 6 weeks after initiation of therapy with the TSH measurement. Lower doses are recommended when initiating therapy in older adults. Hormone replacement for subclinical hypothyroidism is usually recommended with TSH levels equal to or greater than 10. I am not going to go over hyperthyroidism in this lecture, but I want to point out an excellent table on page 532 which compares and contrasts the clinical manifestations of hypo and hyperthyroidism. Here was the slide for the clinical manifestations, diagnosis, and management of hypothyroidism. So the last condition I'm going to talk that impacts the endocrine system is hyperparathyroidism. So hyperparathyroidism refers to a condition of excessive PTH production by the parathyroid gland. Primary hyperparathyroidism is due to parathyroid gland disorders, which are typically caused by adenomas, tumors, hyperplasia, or radiation exposure, and parathyroid adenomas are the most common cause. Adenomas can be single, affecting one gland, or multiple. The abnormal cells of the adenoma resets the serum calcium sensor cells to a higher set point. The adenomatous mutated cells secrete PTH so that calcium levels can reach the new set point. This leads to calcium levels rising abnormally. As the adenoma grows, normal surrounding cells atrophy and stop functioning. Excessive calcium levels can lead to decreases in phosphorus levels, increases in magnesium levels, and metabolic acidosis. Secondary hyperparathyroidism is due to chronic hypocalcemia, and with this, the parathyroid develops hyperplasia, which results in PTH secretion to try to increase the low calcium levels. However, the gland then overproduces PTH regardless of the calcium level, which will result in hypercalcemia with prolonged or advanced kidney failure. The clinical manifestations of hyperparathyroidism include electrolyte and pH balances. Diagnosis is made through a history and physical exam, serum PTH, and serum calcium levels. Serum PTH and calcium are high with primary hyperparathyroidism. If the calcium levels are high but the PTH is low, then the gland is likely intact, and the high calcium may be due to a malignancy or excessive calcium or vitamin D intake. Low serum calcium with high PTH is consistent with secondary hyperparathyroidism, and treatment is determined based on the underlying cause. Tumors likely require surgery and radiation, and calcitonin may be administered to shift the calcium from the bloodstream to the bones. Medications may also be administered to mimic calcium circulating in the blood, and in turn may lead to decreased PTH production. Bisphosphonates can decrease the loss of calcium from the bone and lessen osteoporosis, and phosphates may be administered to correct phosphorus levels, which will decrease calcium levels. Increasing fluid intake will increase renal excretion of calcium and magnesium, and pH imbalances may also need correction.